invitation, and thank you, Dr. Colombo, to come here with us. So I'd like to present a case because since I had 20 minutes, I think that it's better to present a live box case, and this is a CERC CTO case I'd like to share with you. Actually, it's a straightforward case, to be honest with you, I tell you at the first, but we have some discussing point. So you see that from the epicaudal view, we have CERC CTO, we have a nice OM. There is a, I think there is some integrated flow, but mostly flow comes from the LAD. And also there is a stenosis at the ostium of the CERC. I think this CERC should be treated from the ostium up to the distal to the CTO, if you see it. So from other view, we also have LAD disease. You see that LAD is very diseased. So I don't think this patient good candidate for CABG because LAD itself diffusely diseased. And RCA is not bad. Only PDA has subtotal pleated, which is not big vessel. You see that the filling of the PDA. So in this case, we think that we can treat with PCI. The first, of course, we try in this session we tried CERC as well as LAD, and so there is nice collateral from septal to LAD. Yes. Sorry about that. Yes, sorry. I didn't prepare a slide, but this is 60 years old male. Thank you. This is 60 years old male patient. He had diabetes and hypertension as risk factors, and he has stable angina. So in terms of wire choosing, I don't know which wire would you like to use, but to me, I think we have many options. In this case, we have tapered, I could say tapered CTO. We have a side branch. We have a small, it's not a big side branch, but we have, it's also included, small OM. We had sent a wire to LAD for safety reason, and then we went to CERC. To go CERC, it's obviously CTO. It's better to use microcatheter, either microcatheter or over-the-wire balloon. In this case, over-the-wire balloon system also could work with low cost. And in this case, now I had a curve. This is beyond this is pilot 50. So I started with this case with pilot 50. You can use any wires. I mean, feeder XT. You can use Sion Black, I think. Any hydrophilic wire could be tried. You see, I go with pilot 50 up to until pilot 50 stops. I didn't send any microcatheter because I don't want to do dissection with pilot. So I do this. If I send pilot, I let wire go until it stops. If it stops, then I have microcatheter and I do more fine work. But sometimes pilot 50 or any XT or any hydrophilic wires find his way and let it go. Because then sometimes in seconds they go to the distal. In this case, I need to have support of microcatheter. This is microcatheter. I had a microcatheter which is fine cross. So you see, it wasn't that difficult to go distal. But I think in almost 56% of the patients' CTO case like this, you can cross it with pilot 50, pilot 200, or with XT or in hydrophilic wire. In this kind of CTO I'm talking about. And we are now in the distal. This is pilot 50. We can change this wire, but also I think we can use this wire because it's pilot 50. What do you think, Colombo? Do we have to change this wire or we can work over this wire? Because it's not totally CTO wires. What do you think?
If you keep this wire, you really have to be careful for the tip because hydrophilic wire may evaporate. You can change it It's not a must to change, but if you read this wire, you really have to watch the tip very, very carefully, because you may start with a distant tip. In my opinion, I like to change the wire because I have one thing less to work.
I agree with you. Otherwise, you have to keep your eye on the tip of the wire. Otherwise, I agree with you totally. Now, we had some difficulties to push microcatheter in this case. I couldn't push it. You see, there is a resistance. If you see the guiding catheter, I have a resistance. I tried a little bit, but I didn't try that much. I know that sometimes, if we couldn't insert microcatheter, any of them, I think fine cross is good catheter for crossing, at least in my practice. I try several times, but I feel that it's not easy. And now I will remove the microcatheter, and I have to send a balloon over the balloon to dilate. Most of the time, we have nice fine balloons. Mostly they cross easily. So at this time, of course, I had to use this over this Pilot 50 because I couldn't change it yet. Now I will remove microcatheter. To do that, I have three options. The first, extend wire, which is, I think, another cost, or Nanto technique. We can give some pressure onto the microcatheter, and microcatheter almost comes itself. We call it Nanto catheter. And the third is trapping technique. We trap the wire at the tip of the guiding catheter. Mostly we use that these days trapping because we use the trap many times during a CTO case. But in that case, I like to show Nanto technique, and we do Nanto technique in this patient. So we give some pressure with the indiflator device, and actually microcatheter comes back itself. Very easy. And after that, I sent 2O balloon. It was mini track, but a good balloon will cross this. And you see how easily it crossed. This is 2O balloon, cross easily, and I did some dilatation. It starts from the distal because it's 2O balloon. I don't think it harms to distal because OM is not small vessel. We do several dilatation.
Omer, I have a question. The microcatheter didn't cross.
Yes, please.
You couldn't able to advance the microcatheter for the wire, okay?
Yes.
In this condition, you prefer to use a 2O balloon from the start or use a smaller balloon that doesn't fail not to cross on the microcatheter?
Okay, that's a good question. I did it on purpose. Somehow I feel that 2O balloon will cross. Otherwise, I would choose 1-2 balloon. Yeah, 1-2 balloon mostly cross. But if I cross 1-2 balloon, I would use 2O balloon anyway. So open first 2O balloon gives me no harm, gives me no additional cost. So I try 2O balloon first to save one balloon. Yeah, it passed. It passed easily without any resistance. But if it didn't pass, then I will have the finest one, which is 1.2 or 1.0. We have also 1.0 balloons. So
we have another tips and tricks that we can cross with a difficult cross
very good idea.
Because sometimes it's very strange that you have people in the field who can cross what is it the balloon can cross? Usually it's very small balloon.
I agree with you. I think if you couldn't cross with the fine balloons, so the second option could be either a guide extension, which is additional cost to me, or you can do anchoring aniseptals. Anchoring gives excellent sport, actually, anchoring balloon. So this is 2O balloon, 2O30 balloon, and I do dilatation all the way. I had one, because I believe that I cross it through to true. I don't have any subintimal course, I feel. So I can give some gentle contrast. If I'm not sure, we had better not to inject contrast, of course. After this, I think I can now put a stent. Sorry? Right coronary? Yes. Did you ask for what? There is no any feeling. There is no any feeling from the right. Did you ask that question? There is collateral from the septals to RCA, PDA, yes, but not big vessel. So, no, you will see it RCA at the end. RCA is very nice, but one of the branches are occluded. So we see that branch from the collateral. Yeah, but you will see the RCA as well. So in this case, we implanted two stents. The distal, we implanted 2.538. And the proximal, we implanted 2.028. So we stented up to ostium. So I changed the guide wire now. I insert my microcatheter and I change it. So I don't know if you see it. I can come back because I think it's important because what Dr. Colomba said is very important. I think either it's why I cannot come back here. Yeah. Okay, now I'm inserting microcatheter with trapping. To insert microcatheter, I have to trap the wire. Otherwise, wire will go and we can lose everything. So we have to trap the wire when we send anything over the wire. And now you see the microcatheter and we will change it. Now, there was a small branch. Actually, in this live case, I like to show some tip to audience. How can we deal with this small branch during the CTO? So in here, again, I had my pilot, 50, the same wire, and microcatheter. And because I have a reference image, you don't see it as reference image, but I have the reference image on my front. So it's easy to guess where is the OM. Anyhow, with this wire, I could go there, but again, my microcatheter didn't cross again, so I changed it and I did dilatation. And in this case, I don't know, I do this technique very rarely, not much. I will show you something. I don't know if Dr. Colombo or other colleagues will agree. So now what I did, I wired the OM and I wired the small OM. After that, I had to do, I think, some ballooning to do IM. And I sent first 1.5 balloon and I did dilatation. And after that, I had 220 balloon. This is small balloon. Only one marker, 1.5. This is that big branch. We could leave it alone, you know. It's not big enough to put any stent,
Dear
right?
doctor,
We agree with
your
that.
time is up.
Yes, we agree with that. Okay. So, I don't think so. In that position, I wouldn't use drug-electric balloon. But for LAD, yes, I would use drug-electric balloon, which we used. I will show you the result in this case. Anyhow, we did predilatation, and now I stacked circ OM and I park a balloon, 2O balloon at the small OM to protect ostium of the OM, small OM. I don't want to lose it because I cannot recross that small OM. If I try to recross it, most probably I will have a dissection because it was almost, it was subtotal occluded vessel. There is definitely small dissection. So if I try to recross after stent, I think I will lose it, because my wire could go easily subintimal. So as a rule, if we do dilatation of the side branch, we don't want to rewire it. In here, since if I put a stent, that small OM, then I could do mini crush technique here, which is the best and I think the only solution. I cannot do clot, I think. So anyhow, we put a stent 2.538 and we park that balloon at the OM. What we will do, we will inflate the stent and also we inflate the balloon and we will do kissing. When we do kissing, we kiss under the strut, of course. So at the carina, stent is under the malapose because of the substrate balloon. But then I have nice opening of the OM, in theory at least, if I do good pot, the proper pot at the carina. This is implantation of the stent. This is 2.538. We wait sometimes, like 10 to 15 seconds, but we do always post-dilatation.
To the nominal conversion.
Sorry?
To the nominal. You do the stent to the nominal.
Yes, nominal, but we will always do. Yes, yes. Now I pull it a little bit back and I inflated it again and up to 16 in this case. Now I have a balloon under the strut. We do ballooning, kissing. Now, of course, I have malapose part at the proximal of the bifurcation. But after that, when I remove side branch of balloon of the side branch, I do pot, of course. And in this case, we do, and this is the trio 28 stents from the ostium. Of course, we remove the side branch balloon. We cannot jail that way. And after that, we do post-dilatation, starts from the carina. We did dilatation of the 2.5 by trio, and above the bifurcation, we did 3.5 post-dilatation. So we like to do aggressive dilatation, post-dilatation. Yes, I have a J wire in the OM, small OM, yes, J, still J. This is trio, yeah, this is the...
You use the balloon behind the stent. So the balloon behind the stent.
Right.
Why you have that way, you can cross because you have the osteoid.
So in here, I'm okay if I have the flow of that, because I don't think I can put a stent there. You mean the recross? That's the point. If I recross it, most probably I have a dissection because it was subtotal occluded. I did dilatation, so it's very high risk to me to go subintimal. So that's why I didn't do it. I know that I cannot do stent in this patient, even if I have dissection or anything. I cannot do anything.
I know that you know this technique that you put the balloon behind the stent would be ready with dissection in this.
But I leave the wire and then it comes to the lateral wire. Yeah. I never left the balloon outside. But maybe I think we should do what you like to do and what makes you successful. There's no rules. As long as what you do is correct in your practice and your results.
Yes.
So if you
1 minute.
You demonstrated in
2
years
minutes.
that
2 minutes
it's
is fine.
good for you.
Yes.
As long as it's good, it's fine.
That's the point, that you need to have no.
So this is the final result after 3.5. I'd like to show this one.
If you leave the wire jade, most of the time, it can fall behind. But in my experience, I say most of the time. Maybe sometimes I was not able, but very few times. But as I said, if you prefer to go with the 1.5 or 1.5 underneath, nothing wrong. I think it's okay. I may consider to keep the 1.5 only for rescue. If you cannot succeed, then you go with the 1.5.
So Amr had used my 2 minutes, so I need another 2 minutes, I think. So this is final result of CIRC. I think it's acceptable with the side branch. And then after that, we went to LAD to treat. This is 2030, and after that we did 2.5, 25 or 20, directly to balloon. So we did gentle. Of course, we did pre-dilatation first, and this was the DEB. And this is the result. We didn't have that much dissection, and we were okay with this result. And we will call this patient 3 months later to see RCA and also LAD. Let me show you the
dissection that or what?
in here.
Working that in the MCS is an edge dissection or?
No. I think the circ, yes, distal circ. It's oversized. It's because the OM is underfilling long time, but by time it will be the same as proximal, I believe. It's not a small one. I will show you right. Right is like that. PDA subtotal occluded. I think it's nice to treat this PDA as well, because PDA is not that small. We see some flow from the left. So this is the end of the video. Yes.
I assume that this patient had a normal left ventricular function and he didn't infarct before. Am I right?
Yes.
Okay.
Yeah.
If you have the same anatomy and this patient had
This patient has no QA. Yes.
Would you have another strategy here as a staged procedure to look into viability?
For the RCA, you mean?
No, for the same.
Anyhow, I mean, in my practice, if we have a ejection fraction issue, if LV is not normal, we always go with a study for either ischemia or viability for CTO.
Yeah, like a post-coronal infarction with the CTO, would you do the LAD and go for a staged procedure after viability?
Definitely, yes. I think it should be the way. If there is no any viable tissue, why we open that after?
Omar, Dr. Antonio mentioned an algorithm for the definition for revascularization. And this algorithm includes that one of them is to assess the ischemic burden. If the ischemic burden is more than 10%, you go for revascularization. And if it is less than 10%, you can keep the patient on medical treatment. For this condition, you did a very good job for the LAD and the conference. And do you think after that you can do some sort of stress test to judge the ischemic burden before one to intervene for the PTA or to go live?
Yes, very good question. If the ischemic burden is 8 to 10, we can do PCI. If less than 8, definitely I think medical therapy is better, for sure. Yeah, we use that algorithm as well.
Okay, thank you very much, Omar, for this.
Thank you.